Okay, I think let's go ahead and get started. Hello, everyone, and welcome to Short Takes on Disability and Sexual and Reproductive Health presented by UCLA students. I'm Dr. Jasper Estebillo, Director of Training for the UCLA Tarjan Center, and it's my pleasure to be here with you all. Today's webinar will consist of 6 7-minute presentations by UCLA students in Dr. Lauren Clark's Lux course, Sexual and Reproductive Healthcare for People with Disabilities. Following each presentation, we'll have a 3-minute Q&A. And to participate in the Q&A, please enter your questions into the Q&A function on the Zoom toolbar, and we'll facilitate discussion after each talk. To start, I will introduce our professor, Dr. Lauren Clark. Lauren Clark is a nursing professor at UCLA and the Shapiro Family Endowed Chair of Developmental Disability Studies. As a public health nurse, she has focused on quality of life for people with developmental disabilities and their families. Her research addresses disability and healthcare disparities, quality of life, and preventative care. She teaches in disability studies, serves as faculty at the UCLA Tarjan Center, and was recently appointed to the Board of Disability Rights California, as well as the president-elect of the Western Institute of Nursing. All right, and with that, I will now hand things over to Dr. Clark to provide background and introduce the class members and their topics for today. All right, I'll hand things over to you, Dr. Clark.
Thank you so much, Dr. Estebillo. I'm so happy to be here. And I have to say, I'm incredibly proud of the students who are in the room. They're going to be addressing you one by one in just a minute. But before we get to the student presentations and short takes, let me give a little bit of introduction to what it is you're going to be seeing today. This is a course that was funded in part by a grant from the U.S. Department of Health and Human Services Administration on Community Living. And it was designed by myself in collaboration with Adam Kippust, and he came to class once. He's a medical, a soon-to-be medical student at University of Miami. He just finished a disability studies minor here at UCLA. We also worked with Kate Schaller, an instructional designer, and Keisha Weller. And Keisha, as you will see in just a moment, was instrumental in making our unfolding case study, which was sort of our learning experience throughout the quarter, come alive. Anne-Marie Lawrence joined us, and she is a child of deaf adults, and as a native sign language speaker and kind of an aspiring ASL interpreter, she came to class and helped us with all of this. So many thanks to the Disability Studies Department, the Tarjan Center, and the federal government for that grant. So today I'm going to give you a brief overview of the course so you can understand where the students are coming from as they give their presentations. I'm then going to introduce the lineup of speakers, and then I'm going to wrap up and suggest that you think of questions that you can ask our students after each presentation. So here is the opening slide. It's a Georgia O'Keeffe piece, which we thought went really well with sexual and reproductive health. And the course overview that I'll give you in just a second features this unfolding case study. More and more in medicine and nursing, we're using unfolding case studies where students have a chance to meet a patient or an individual in a healthcare setting and then watch their healthcare story unfold. So I'm going to give you about 45 seconds of the second part of this unfolding case study, just so you'll have a sense of how that works.
Sarah Gordon is now 20 years old and is 18 weeks pregnant. She is currently attending a monthly prenatal visit with her healthcare provider. Sarah expresses excitement and joy over getting to be a mother. Sarah's friend, who has a disability, lost custody of their child. This happens because of child neglect and a Child Protective Services investigation. When it comes to child protection, Sarah and her friends, along with their families, believe the U.S. treats disabled parents unfairly.
So you can see there that this unfolding case story gets more and more rich and deep and complicated. So as we followed the unfolding case study throughout the class, we also talked about all kinds of issues related to sexual and reproductive health. And as our viewing audience, I just wanted to give a little reminder. Sexual health refers to the possibility of successful sexual relationships, the possibility of having pleasurable and safe experiences without coercion, discrimination, or violence. Reproductive justice, we talked about as well, the right to have children, the right to not have children, the right to nurture the children you have in a safe and healthy environment. And the case study touched on each of these aspects of the experience. And then disability justice is kind of an overarching framework in disability studies that refers to the values of access, intersectionality, and leadership of the most impacted. So those were some of the topics we talked about. The students were then able to choose any of the topics on the left, and they signed up and then have been working all quarter to develop a 7-minute presentation for you. And I look forward to having them present. As soon as they finish, there will be a slide that comes up that gives Q&A, and that will be the cue for our studio audience to ask any question you might have of the students. So again, my applause to the students and welcome to the floor, Hannah and Marisol.
Hi, everybody. My name is Marisol Mercado, and I'm a first year at UCLA studying education.
Hi, I'm Hannah. I'm a first year as well, and I'm studying math.
And we're going to be talking about sexual education for people with disabilities.
So first, we're going to start by defining what exactly sexual education is. It's an education program that's easy to understand and encourages natural, healthy sexuality. This program includes information on infections that pass from person to person during sexual activity, birth control, healthy relationships, and anatomy. This is usually taught in schools once to middle school students, and again, a more advanced or detailed information is given to high school students. It allows young people to learn about and have access to resources regarding sexual health and sexuality.
And here are just some statistics on sexual education within the US. So only 18 out of 50 states actually require that the program is medically accurate and evidence-based. So with this, it means that the rest of the 50 states could use information that is either like religious-based or things like that, but isn't necessarily medically accurate. Additionally, only 6 out of the 50 states offer optional extra materials to help people with disabilities learn. This can be extra resources, a presentation in plain language, and things like that. And then only 3 out of the 50 states clearly include people with disabilities within their sex education requirements. So that can be whether in examples or just expressing that people with disabilities also have healthy human desires and sexuality.
Okay, so why is sexual education important? 2 of the main reasons that we're going to talk about are autonomy and consent. So to start, autonomy means freedom for everyone to make their own choices with their bodies, and access to education and resources is a basic right for everyone. It's important for both reproductive rights and for people with disabilities. When people have access, they can learn how to control their own sexual experiences, and that's what autonomy is all about. Next, to define consent, it's an agreement between partners, and in the case of sexual education, we're referring to an agreement to participate in some kind of sexual activity. This should be given freely and enthusiastically, and everyone involved needs to consent for the sexual activity to happen, or else it involves coercion or sexual violence. Evidence shows that sex ed programs can reduce relationship violence by about 60%. And it reduces violence because people are more aware of unhealthy behaviors in their partners and are also have the resources to better advocate for themselves. It also makes people feel more comfortable talking about these subjects and destigmatizes conversations around sex and sexuality.
And then there are concerns for people with disabilities, and these concerns are what leads to the lack of sexual education for people with disabilities. The first one is ableism. People with disabilities are often not seen as sexual beings with natural human desire, and as we know, this is untrue. So the deep roots of ableism within our country is what makes it that people with disabilities often don't get the same opportunities for sex education as everybody else. And then another one is guardianship. So guardians can stop students from receiving sexual education and also block their privacy with healthcare providers. So if someone is under a guardianship and they're over the age of 18, this can stop them from getting their private conversations with healthcare providers, if that's about birth control, just about sexual education in general, or things like that. And the same way for students, guardians can stop them from receiving a sexual education that could actually be for the student's benefit. And then finally, vulnerabilities. So being left out of sexual education makes people with disabilities more vulnerable to sexual assault and being used. And this isn't just for people with disabilities. Anybody left out of this program can be more vulnerable because they don't get to learn about consent and unhealthy relationships and just signs that could potentially help them in the future.
So what improvements can be made? So the first one is trust. So educators need to feel comfortable talking about disabilities with everyone, and students also need to feel that their teachers are supportive and inclusive in order to build that trust. Second is inclusivity. So the materials should reflect the students in the classroom and the people learning the materials. They should also be easy to understand and accessible for everyone. Access. Sex education should be part of special education, just like it is for the standard curriculum, like how we discussed how it's taught in middle school and high school. So it's important for all students, no matter their ability to be a part of this program when they're at this age. And then policy, officials must protect access to sex education for people with disabilities. So politicians and school boards, basically just the people who have the power to make the change in policies, need to advocate for these things.
And then here's like a quick review of our sources and our references for what we use to create this presentation. And then with that, did anyone have any questions? I don't know, is there a question box that we're supposed to have open?
So Dr. Estebillo may be able to say if someone's asking a question.
Reminder to our audience to please submit your questions for our wonderful speakers into the Q&A function. It looks like a little thought or a speaker bubble with a question mark on the bottom of the toolbar. But for the two of you, I do have a question. I know that I was very struck by some of the statistics and background information that you offered in your talk. But in preparing for this presentation, what were some of the things that you were either most surprised by or motivated into delving deeper into this topic? What were some things that surprised you?
So I'll answer first. I actually teach sexual education at local high schools here in Los Angeles and mostly to minority students. And because of that, like I got a firsthand view of like all of our materials and everything that we teach. And I really liked how we don't just teach about sexual health. We also teach about like relationships and things like that and like boundaries and how to talk to people and communication. And it really surprised me that when I started taking this class that I realized like we don't talk about people with disabilities and we really don't include plain language and ways for people with disabilities to actually connect with our coursework. So that's why I wanted to take this class and I wanted to talk about this because I want to be able to, in like my next upcoming presentations, actually make it more inclusive for people with disabilities. And I wanted to share like the statistics about how it's not inclusive right now.
Absolutely. And thank you for your work and for educating our communities. I think that that's such an important piece in recognizing that as we as educators or individuals in this community continue to strive for more inclusive spaces, that we really need to identify what are those holes and gaps in the things that we're already doing. So I think that's a really good point. Any additional thoughts from your co-presenter? What were you struck by in preparing for this presentation?
I guess like one of the main things I was struck by is how few states have like regulations about including diverse like perspectives of like people with disabilities in sexual education. For example, like how we discussed only 3 states require that. And so that really struck me. And so I think like that it's really important for like us to talk about this and raise awareness about this issue so that it becomes more inclusive.
Absolutely. I'm also seeing a question from one of our audience members that speaks to that. So they were asking which 3 states require special education or require content about individuals with disabilities to be included in sex education?
That's a good question. I don't know if Ms. Clark shared the presentation, but I would definitely look more deeper into the references that I said because they were super good at providing all of that information. I'm sure she would be glad to share that. And if you look more deeper, you can definitely find out which states do provide that. Yeah. So the biggest one was the first one, yes, discussing accessing capacity for sexual consent. And then the second one about just the national sex education standards. Those two were like the best resources for me when it came to looking for all this information and finding these statistics. I can't remember the exact states off the top of my head, but I would definitely look deeper into those.
Yeah, thank you for putting up these references. And I encourage all of our audience members to take note of these references and also use this as a motivating factor to advocate for the things that we're interested in. I'm also seeing a question from another attendee regarding any action items, so federal action that could help make up for disparity between state laws. I think that's a big question, maybe one that we can't fully tackle during today's Q&A. But I'm seeing, based on your two very emphatic head nods, yes, whatever actions we can, whether it is contacting our representatives, voting, right? It's an election year. All of those things are actions that we can do to either highlight or, really advocate for these disparities between our state laws. But thank you to you both for this wonderful presentation. It was so wonderful to have you present this important and informative talk. And I think with that, we will hand things over to our next presenters. Thank you both very much.
Hello, welcome. Today we're going to be discussing the accessibility of healthcare for people with disabilities. My name is Jocelyn Cruz.
My name is Eli Whitaker.
So some things that we're going to be talking about is what guarantees accessibility. So we're going to be talking about a combination of legal frameworks, policies, along with additional funding that should be granted towards accessibility, especially within the medical community.
And then we're going to talk about the accessibility of healthcare today. We're talking about barriers faced by both the provider and the patient side and some firsthand accounts of that.
We're also going to be talking about potential practice and policy intervention. So how can we create further education awareness or campaigns and how we could further promote healthcare access, especially amongst the disabled community. So the ADA is a law that was passed in 1990, which is the foundation of all discrimination rights in the US. This basically ensures that public services provide inclusive architecture to people with disabilities. So having ramps, having accessibility, more accessibility for public transportation, modifications, and additional services that would further accommodate people with disabilities. Some things that it does prohibit is the refusal of service towards those with a disability solely on the grounds of the disability itself. So basically not being prejudiced towards a certain group, and also providing a different or lower level of service of benefits to people with disabilities. So again, treating people equally along all spectrums of disability.
Yeah, and so talking about how this is actually implemented, we're going to discuss the accessibility of healthcare today. We looked at it through two different lenses, one from the provider side and one from the patient side. So we found a focus group from 2018 that was funded by the Eunice Kennedy Shriver National Institute of Health and Human Development that looked at 3 different groups of physicians. There were rural and non-rural primary care physicians as well as specialists. And I've gone ahead and kind of outlined 4 of the main concerns and barriers they discussed. One of them was relying on caregivers. This is more in relation to people who require an aid if you're hard of hearing or need an ASL interpreter. A lot of the providers admitted not having that sort of service ready for the people with the disabilities and instead rely on the caregivers to provide that service. Another barrier they face is inadequate expertise. The physicians said, for example, that they would not be properly trained to physically transfer patients with a disability without harming themselves or the other patients. The biggest one to me and the one that was most surprising was a discriminatory attitude. By this, I mean the providers find accommodating people with disabilities burdensome and see it as a challenge. There are some quotes that I pulled from this focus group. For example, they said they can create a big thing out of nothing And one big quote, which was actually the title of the article, is, "I think you need a lot more care and I'm not the doctor for you." So there's two different lenses in denying care for people with disabilities. There's one side that views providing these accommodations as more work, and there's another side that notes that they would not be able to adequately help people with the disabilities and accommodate them, and they would deny them service because they know that they would not be able to provide the level that's required. And the final barrier that was seen by the provider side was their knowledge of the ADA. According to the doctors, which was in the focus group, they said that the Americans with Disability Act was not something that was mandatory in consideration for their medical in their medical school, and a lot of them admitted not knowing what was required and what was prohibited by the law, which is pretty interesting. And so from the patient side, we have a research article that was by the Association of Women's Health, Obstetric and Neonatal Nurses in 2021. These are firsthand accounts from people with disabilities and their experience in receiving medical care. Again, there's 4 main groups that I outlined in their concerns. Unaccommodating architecture, which is pretty standard complaint with people with disabilities. It could be doorways being too narrow or ramps not being steep enough or not having ramps for them to physically access it, which is a pretty blatant violation of the ADA. Another is inadequate medical equipment. For example, if somebody is in a mobility chair and cannot physically transfer themselves, if there's a medical bench that doesn't have an adjustable height or an X-ray machine that doesn't have the right equipment, these people are not able to receive the care they have. And a quote that I pulled from this article, just on the left, says that they basically have said, like, if you want to use a lift, you need to find somebody else. This ties into what the provider said, where they just don't have the adequate care. Another barrier that the patients said was a lack of social consideration. A lot of them found that providers were condescending and would often patronize them. Instead of talking directly to them, the person with the disability, providers would often talk to the caregiver and completely disregard the person with a disability and treat them like children. And a final issue that they found is kind of in consideration from their aides that would be provided. For example, if there's an interpreter that needs to read out medical information, they found that they were not well accommodated and that their private information would be said, for example, in a lobby or not being received the level of privacy that somebody without a disability would get.
So some potential practice and policies that we can keep in mind is, how can we solve the gap in treatment between able-bodied people and people with disabilities? This is often created from ignorance and misinformation. Some things that we thought of that could be done is sensitivity training, especially amongst providers, just to help aid, just to help make a better and more safe environment for the provider and the person. Also, increasing access and availability of medical equipment along with funding. By doing this, we would ensure that there would be more equipment, and it would also provide for a better experience between the patient and the provider. Currently, there are actually still 31 states that support forced sterilization. So one way that we can combat this issue is by creating advocacy towards reforming the guardianship policies of reproductive health amongst people with disabilities. We firmly believe that if somebody is capable of bearing a child and they have all the resources and the support, they should be able to decide that themselves. And I guess just to end things with the lasting note is being more self-aware, especially as an able-bodied person and an able-bodied person in the medical field. Our next slide is just our references that we used to create this presentation.
Open it for any questions, if there's any.
Great. Thank you so much, Jocelyn and Eli, for that fantastic presentation. I will give our audience just another moment to type in their questions. Okay, I'm seeing a question here from an audience member. In preparing for this talk, did the two of you notice any kinds of education that's provided in medical schools for more inclusive care? Or if there's any differences across medical schools in this regard across the country? Was there anything that you were able to see in preparing for this talk?
Not preparing for this talk, we didn't find any trends specifically in medical schools like distributed across the nation, but we did the providers that we did look at for the case study were from different parts of the nation, and they all kind of had the same general consensus across all three groups that the knowledge about the ADA was not something that was very mandatory in their medical training.
Any additional reflections in preparing for this talk? I know, Eli, you had noted in particular on the provider side, the discriminatory attitudes, but other things that you were particularly struck by when doing this literature review and preparing for today's talk?
I just think probably the lack of funding, especially within the just the disabled community and the medical community. I just would have figured that there would be a lot more resources for that particular group, and just the lack of people that follow the ADA. There were like certain testimonials of people that just kind of, they felt very neglected by the system, although those policies were in place.
Mhm. Yeah, I'm wondering, I was certainly struck by both the provider and the patient perspectives. Do the two of you, I know that we might be talking more grand scale things, but in speaking to both the provider and the patient sides of things, is there any kind of ties between the two different areas that you notice, or ways that you would recommend a patient can advocate for themselves so that way a provider is more informed?
I think we kind of thought more of maybe like rallying as able-bodied people and maybe kind of being their voice to kind of create just more awareness. Because I do think that it does stem from a lack of awareness and maybe a little bit of ignorance as well.
Yeah, I think something that Dr. Clark and certainly Keisha Weller are very strong advocates for is that nothing about us without us is a very common thread and theme in working with individuals with developmental and intellectual disabilities. So listening to the voices of those who we aim to serve and really amplifying their concerns, so that way we are providing more inclusive, not only healthcare, but the settings that we work in. All right, well, thank you both for this talk. I'll make sure that we're keeping on time. So we'll go ahead and prepare for our next presentation. Thank you both, Eli and Jocelyn.
Good afternoon, everybody. My name is Isaac Guevara, and this is
Silence Jackson.
And today we came here to talk to everybody about contraception. Before we get started, we'd like to give a little definition of what contraceptives are. Specifically, they are also known as birth control, but they include drugs, surgeries, and devices that are used to prevent pregnancy. Aside from preventing pregnancy, these methods also help promote freedom and ease the pains of heavy flows of menstruation, which would allow for more independence. We wanted to introduce a sample case study where you guys would meet Claire. Claire is a 30-year-old female who has an intellectual disability, which affects her memory as well as her ability to travel. She currently does not want kids and is interested in using contraceptives. The way for Claire to even use contraceptives would be to even get her hands on them, which means she would have to go to a Planned Parenthood or a clinic, which have made strides in nationally having contraceptives accessible to all people who are able to request them. Though these moves are grand and very appreciated by the general public, there are certain barriers such as independence, transportation, as well as ableism that prevents people, perhaps like Claire, to even get their hands on them. To delve deeper into these barriers, we'd like to talk about independence, where guardians or caretakers of certain people prevent them from accessing contraceptives for a variety of reasons, but mainly because they don't believe these people have the freedom to be sexually healthy in their lives. Additionally, transportation, and such as our case study, Claire, who has an inability to travel, such as not being able to drive or not being able to take public transport, to be able to get to these locations where contraceptives are being given out, makes contraceptive access more difficult. And finally, ableism in doctors, nurses, or even the guardians, where these services aren't provided or aren't even suggested to certain patients just because they aren't believed to have that sexual freedom or have the capabilities that people without disabilities may or are seen to have.
So I'm going to dive into the different types of contraceptions, and especially in the disabled community, these people that are disabled or have certain things that they need help with, they don't even know that they have these different types of contraceptives available. So we believe that it's very important that this education is implemented. So there's two different types. There's administered contraception and also self-administered contraception. I'm going to start with administered first. And basically, I have 3 examples here. The first is an IUD, 99% effective. It's very long-term, 3 to 12 years, and you need a one-time doctor visit, and that's very important. People with different types of disabilities, they may not be able to regulate a schedule or remember things on a timely basis. So things like administered contraceptive, like an IUD, is very important because they can have the protection and conduct healthy sexual activity without worrying about side effects or forgetting and things like that. The next example is an implant, also 99% effective. A popular one is called Nexplanon. It is advertised very widely and commonly. Also long-term, lasts up to 5 years. Again, one-time doctor visit, which is very important for people with different types of disabilities. And the last example is a birth control shot. It is more long-term, but not as much as the first 2. It's about every 3 months visit. So again, people with disabilities can utilize this form of contraception, but it does have a small time regulation. The second type is self-use contraceptives. These are more on the individual. So the first one is a birth control patch, 93% effective, no doctor needed. You change the patch every week. I think of this kind of like the shot, which is every 3 months, but you do have to remember to change the patch every week to remain protected. The next is the birth control pill, and this pretty much drifts into the more individual self-use contraceptive because it's a pill that has to be taken around the same time, every single day, no doctor needed, so you don't have to have that doctor visit, but is solely the person's responsibility to take the pill every day to remain protected. And the last one is condoms, which is the most common type of contraceptive that is utilized, and it's 87% effective, but it's on the individual to keep track of having the correct supply and using it every single time before sexual activity. So based on our example case study, for this presentation, we decided that Claire should use an IUD. Since she does not want children in the near future, she has trouble remembering things as well as transportation. The IUD lasts 3 to 12 years, and you only need 1 visit, and it can be planned according to her needs based on like if she has a provider and the medical provider that she gets it from. So in summary, our presentation covered contraception, which in order to prevent pregnancy and ease menstruation, and also to expand transportation, ableism, and guardians can be barriers in this topic. And we had our example case study, Claire, that we decided that she should use an IUD as the best option for her and to work around her disability. And also there are various methods of contraception and that exist, and with the advice, finding the right one is easy, even if it's assisted or not. And these are our references that we use to conduct our presentation. Thank you.
All right, well, thank you, Silence and Isaac. A reminder again to our audience to type in their questions for our speaker into the Q&A. Let me see here. I'm seeing one question about explaining female condoms. Would one of you be able to speak to that form of contraception?
So pretty much female condoms, there's condoms that can be used specifically for male genitalia and female genitalia. And pretty much it's just finding the right one. There are videos that can explain how to properly utilize any form of contraception, really. The most commonly used is for male genitalia specifically, and that's the most easy to use one. And also it is the highest form of effective contraception that is the least invasive.
Thank you, Silence. I'm also seeing another question about IUDs. Does the IUD also have an impact on menstrual discomfort?
Yeah.
Yeah, sorry. Especially like through our research, IUD, it is the most long-term form of contraception. It is invasive, however, but it does vary from woman to woman how impactful an IUD can be. And that is why it's important to talk to your healthcare provider, especially with advancements in technology. It's easy to talk to a professional, a phone call, video chat, or in person, which is very inclusive for the disabled community.
Yeah. For the both of you in preparing for this talk, any other thoughts or suggestions that you would have for an individual with disabilities on maybe what questions to ask their provider about contraceptives or things that they might want to advocate for in terms of their needs when discussing next steps with their medical provider?
For specifically as far as like what to use, definitely having a detailed idea of what your future plans are as far as having children or not having children, but then also just staying in contact with your provider about your certain side effects if you have any, or if you experience any discomfort with the specific contraceptive you use. Definitely with the more invasive types, are more likely to experience more discomfort, but comfort and longevity of your own health is something to keep in mind as far as using contraceptives.
Also to add on really quickly, if you are like an example for someone that has neurological disabilities or something of the sort, it's very important to let your healthcare provider know basically the limitations that come with your disability. That way they can help you plan accordingly and help pick the contraception that's best for you.
Absolutely. So reflecting on those questions about more short-term and long-term goals, family planning, as well as sexual health. I think that those are certainly very important. Thank you both. I'm also seeing another question about explaining the difference between the morning after pill, or what's commonly called Plan B, and contraception. So what are the differences between the two?
So pretty much a Plan B, I would like to say, is a secondary intervention. So pretty much this is after the fact, and like basically you're trying to make sure that nothing happens or prevent pregnancy and things like that. Contraception is what I like to call a primary intervention. It's something you think about before you're sexually active, or you talk to your partner about that before sexual activity. So it's pretty much before the sexual activity takes place.
Yeah, I think also if we look at just the word contraception, so contra means against, or against. So that works to prevent pregnancy. I'm also seeing another question here that so many contraceptive materials depend upon the woman. What advice might you have for a young man with a disability in terms of navigating these kinds of conversations or contraception within the context of sexual experiences?
At least for what I researched, I've seen that there aren't many advances as far as male contraception. Our biggest thing is using condoms and having those available regularly. So if this specific individual can have that near them or wherever they may feel they may be sexually active, that would be very helpful. But also speaking with your partner and consensually, just like speaking about what contraceptives they would be using, what contraceptives the individual themselves would be using, how and when that would work. Having these conversations consensually and safely, it's what's going to make their experience and overall health the best.
Absolutely. All right. Any additional thoughts from the two of you on contraception, or how we might be able to talk about this with individuals with disabilities? Any kind of lingering thoughts or takeaways that you want to share with our audience?
I think at least for me, as far as touching on that last point where many contraceptives are used or are for women, I think I'm glad to see that there are advances for male contraceptives. Specifically, one I've been seeing is sort of like insertion, where a gel is used as a sort of spermicide, and you do not have to manually reapply this every time you are sexually active. But having this as an asset for males with disabilities who may be sexually active can help in engaging as well as balancing that sort of contraceptive imbalance that we see today.
Absolutely. I think a big part of it is open discussion, really empowering individuals, regardless of disability status, to openly communicate, advocate for themselves, and to care about their healthcare. Does not have to be taboo. But I think, Silence, were you going to jump in and have additional thoughts to offer?
In terms of our presentation, I think it was really informative for both of us to not only just learn about contraception. I mean, we've had a previous presentation that focused on sexual health and education, but also just for the disabled community specifically. We wanted to basically educate ourselves on basically the different types of contraception because there are so many options out there, and many people, even able-bodied people, don't know that these options are available for them and that they can basically have a say in their sexual health and essentially their reproductive health as well.
Absolutely. Well, thank you both, Isaac and Silence, for this wonderful presentation. We'll go ahead and move on to our next talk, but it's been a pleasure speaking with you and learning about contraception. Thank you.
Hello, my name is Evelyn, and I'm going to be talking about sexual violence against people with disabilities. So here's an overview of what I will be covering today. First, I will highlight a powerful NPR podcast that reports on sexual assault against people with intellectual disabilities. Then we will look at some of the key facts and statistics about sexual violence and disabilities. And finally, we will discuss some possible solutions that can help address this issue. Before we begin, however, I want to let everyone know that this presentation will discuss topics related to sexual violence and assault, which may be distressing for some individuals, so please feel free to step out or take a break at any point. So I wanted to highlight a podcast series from NPR titled Abused and Betrayed. This series explores sexual assault within the disability community and covers a range of topics, including the challenges and successes prosecutors face in bringing these cases to court, and the efforts of various states to stop the sexual abuse of people with intellectual disabilities. So I've included a QR code on the slide for those who would like to listen to the entire series on their own, but today we will be focusing on a particularly powerful episode from the series that sheds light on several firsthand accounts of sexual assault against individuals with intellectual disabilities. Hearing these personal stories highlights the realities faced by many in the disability community, and from them we can identify some common experiences shared by victims of sexual violence. One of these common experiences is perceptions and stereotypes. So harmful misconceptions about people with disabilities often contribute to sexual violence against them because they create a false sense of vulnerability, making individuals with disabilities seem like easy targets. Several stereotypes and misconceptions keep alive the false belief that individuals with disabilities are inherently weak or incapable of protecting themselves. And here are some quotes shared by individuals in the podcast that acknowledge how these stereotypes affect them. Another concerning aspect of sexual violence against people with disabilities is the fact that perpetrators are often individuals who are supposed to be providing care and support. Individuals with disabilities may rely on family, caregivers, doctors, staff members, or other authority figures for assistance with daily tasks and activities. Unfortunately, these trusted individuals may exploit their position of power and authority to carry out acts of sexual violence. And this quote on the right vividly illustrates this reality through the experience of Sam Maxwell. The next common experience we will talk about is pain and awareness. So sexual violence is known to inflict both physical and emotional pain on survivors, but individuals with disabilities are often subjected to additional challenges and misconceptions in acknowledging and addressing this pain. One common assumption is that individuals with disabilities may not fully comprehend or feel the emotional and physical impact of sexual violence, which can lead to further neglect of their experiences and an underestimation of the severity of the trauma. In reality, disabled survivors experience profound physical and emotional pain as a result of sexual violence, regardless of their ability to articulate or express it. Lastly, fear and silence often surround the experiences of individuals with disabilities who have survived sexual violence because they often face disbelief and stigma. So when survivors gather the courage to disclose their experiences and encounter skepticism or outright disbelief, this invalidation of their experiences can further discourage them from seeking support. They also fear being unfairly blamed, adding to their distress and making it harder for them to share their stories. Okay, so now that we've discussed some of the common experiences, we are going to zoom out and look at this issue from a broader perspective. So in this section, I'm going to be talking about some concerning statistics and key points surrounding the hidden epidemic of sexual violence against people with disabilities. So in the United States, startling statistics reveal the grim reality of sexual violence against individuals with disabilities. According to a 2009 report by the Department of Justice, approximately 47,000 rapes were perpetrated against people with disabilities. And shockingly, more than 90% of individuals with disabilities will experience sexual abuse at some point in their lives, regardless of their gender. Still, women and girls with disabilities are 3 times more likely to become victims compared to those without. Despite these alarming figures, only a mere 3% of sexual abuse cases involving people with developmental disabilities are ever reported nationwide. So why is this number so low? One key contributing factor is the lack of or limited access to comprehensive sex education for people. Without proper education and awareness about healthy relationships, boundaries, and sexual consent, individuals with intellectual and developmental disabilities may struggle to understand what constitutes appropriate or inappropriate behavior. As a result, they may be unable to recognize signs of abuse or understand that they have the right to refuse unwanted sexual advances. Survivors may also be hesitant to come forward about sexual violence, particularly if the perpetrator is a caretaker or authority figure. The fear of negative consequences, such as losing access to essential care that supports their independent living, can deter them from reporting. Additionally, as we briefly touched upon earlier, there's a pervasive issue of disbelief where individuals with disabilities may not be taken seriously when disclosing sexual assault due to misconceptions about their capabilities. And even if they do overcome these barriers and seek support, they may encounter additional challenges in accessing crisis services. For instance, rape crisis centers may lack accessible buildings or services, and many service providers lack sufficient training in supporting victims with disabilities. Without proper planning and protocols in place, service providers struggle to adequately support victims, further maintaining the underreporting of sexual violence in this community. So next, I'm going to briefly discuss the challenging landscape of sexual violence and disability in the courtroom. So it's a sad reality that the sexual assault of someone with a disability is often one of the easiest crimes to get away with. But one case that did end in a conviction was the Glen Ridge rape case. This case marked the first time the sexual assault of a woman with an intellectual disability gained widespread national attention. And while I won't get into the details of this case, it involved a young woman from special education classes who was lured into a basement by a group of popular high school athletes under the pretense that if she went with them, she would get to go on a date with the football player she had a crush on. And despite the presence of 13 individuals in that basement, no one intervened to help her, nor did they report it afterward. At the trial, defense attorneys tried to portray the young woman as an aggressor who actively pursued sexual encounters, but her attorney noted the limitations that came with her disability, explaining that she had difficulty understanding that she could say no to her classmates. And when asked why she didn't ask the boys to leave her alone, she replied that she just didn't want to hurt their feelings. So in the end, 4 of the young men were convicted. So around the time of the Glen Ridge trial, prosecuting sexual assault cases involving individuals with intellectual disabilities was rare. Research conducted in 1994 revealed that even when offenders were identified, only 24% were charged with an offense, and of those charged, only 8% were convicted. Now let's consider some more recent data. In Texas, less than 1% of sexual assault allegations are ever confirmed. In Florida, about 5% are proven true, and in Ohio, about 23% are proven true. In Pennsylvania, 34% of claims are confirmed, but only 40% of those are reported to the police. So again, why are these numbers so low? First, some victims with intellectual disabilities may struggle to articulate their experiences due to communication barriers. In some cases, they may lack the verbal skills necessary to express themselves effectively. Even when they can speak, they may have difficulty providing precise details, making it easy for them to be confused or misunderstood in a courtroom. Additionally, these cases require prosecutors to undertake significant additional efforts to support victims through the legal process. This includes educating victims about their rights, guiding them through court proceedings, and advocating for accommodations to facilitate their participation. So some of those accommodations include service animals that are trained to provide emotional support during testimony, or videotape testimony so that it can help alleviate the stress and anxiety associated with facing a jury in trial. So next, I'm going to talk about some possible solutions aimed at addressing sexual violence against individuals with disabilities. So the first solution is to provide comprehensive education and training programs tailored to individuals with disabilities and their families, focusing on sexual harassment and assault awareness. These programs should offer practical guidance on how to recognize signs of abuse and inappropriate behavior, as well as how to respond and seek help. Reporting systems should also be made easily accessible and user-friendly for individuals, and they should be private and confidential to encourage survivors to come forward without fear of stigma or retaliation. Responders such as law enforcement officers, healthcare professionals, and victim advocates should also receive specialized training to effectively support survivors. And access to a range of support services, including counseling, medical assistance, legal aid, and advocacy should also be expanded. We should also foster collaboration between different organizations to ensure comprehensive and coordinated support for survivors. We can also continue to work on making support services easily accessible by addressing barriers such as transportation, communication, and physical accessibility. Ultimately, by implementing these comprehensive strategies and interventions, we can work towards creating a safer, more inclusive, and more supportive environment for individuals with disabilities who have experienced sexual violence. And to put into perspective what a safe and supportive environment can look like, I want to show you Winona's house. So 15 years ago, the state built this Child Advocacy Center in Newark. It's designed for children who have been physically or sexually abused, and it houses healthcare professionals like therapists and nurses who can conduct rape exams. Police and prosecutors also work there, collaborating effectively with the therapists and nurses, but they are kept out of sight to maintain a less scary atmosphere. And while it was made for children, Winona's house also serves adults with intellectual disabilities, recognizing their unique needs. So the center exemplifies how we can create safe and supportive spaces for survivors of sexual violence. And that is a quick summary slide. And those are my resources.
Thank you, Evelyn, for that very thorough talk. And thank you also for presenting on such a heavy but critical topic to share with our audience. Audience members, another reminder to please submit your questions for Evelyn into our Q&A. I'll go ahead and start things off. Evelyn, I think that so many of the statistics that you provided today were very simultaneously shocking, but also very disappointing. And so I think that in particular for myself, that statistic that 90% of individuals with intellectual and developmental disabilities experience sexual abuse regardless of gender. Was there anything that particularly struck you or that you found to be especially important to highlight during today's talk?
Well, yeah, I think the statistics were really important because they are really shocking and really disappointing. But for me, it was personally the 3% that get reported, considering how many assaults and rapes occur nationwide. For only 3% to ever get reported is really disappointing.
Absolutely, right, that we know of. And so it's probably likely even lower than that. And so I'm just seeing some nice comments here in the Q&A. Thanking you for that trigger warning and also empathizing that the system meant to help victims of sexual violence more likely than not re-victimizes those victims. And I think that was very clear during your presentation. I also appreciated, Evelyn, your next steps in terms of education and training, improving reporting mechanisms, as well as providing some support services. Were there any specific avenues that you were particularly interested in or found to be some potential next steps in addressing sexual violence against individuals with disabilities?
Well, I think the best way to start is with education. I think it's really important for people to be able to recognize when something wrong is happening. And yeah, without education, people don't know about where they can report it or how to report it. So I think that's a great first step.
Absolutely. So things like teaching appropriate body boundaries and respecting them with other people, consent. Those are very foundational concepts that I think are important to teach, not only after the fact, but as a preventative measure. Absolutely. Any other things in terms of education and training or reporting mechanisms, support services that you found to be secondary or also important to share with our audience?
Yeah, I did find that, I don't know in what state, but they're now like teaching police officers like new interview techniques to work with sexual assault victims. And they're basically teaching them how to ask more concrete questions because a lot of people with disabilities don't want to seem like they don't understand what's going on. So by asking concrete questions, they can give very easy answers and probably get the details that the police need to create a case.
And I think concrete questions are particularly important when somebody's experienced a trauma. It takes away some of that responsibility on from the survivor to the person who's actually is their job to gather that evidence. I think that's very important. I'm seeing a question here from the audience for you, Evelyn. So having researched this issue, what has changed for you and your thoughts about your future, if any?
So I personally am more interested in like the legal side of this, which is why I included that court case. So I don't know, I never thought about, representing people who have been victims of sexual violence. And reading articles about a lot of lawyers not wanting to take those cases because of how hard they are to win, makes me want to fight for those people, so.
Well, I hope that your takeaways are to continue to advocate. I think that regardless of your next steps, that you'll be successful in whatever avenue you decide to pursue. But thank you so much again, Evelyn, for this presentation and for sharing this topic with us. Let's go ahead and move on to our next talk, and we will hear from our next speakers in just a moment. Okay.
Hello, my name is Lucia, and this is
I'm Robin.
yes. So we will be talking about prenatal screening and testing for aneuploidy. So, what exactly does that all mean? So prenatal screening is a medical test that tells you if your baby is more or less likely to have genetic differences. And an expecting mother will go to a pregnancy clinic or general medical office and have this process performed by a healthcare professional. And prenatal testing is the process that the genetic sample goes through. It's sent to a lab and tested for chromosomal abnormalities. And the background information behind this is that the human genome has 46 chromosomes, and the aneuploidy is when the fetus has more or less chromosomes that is than 46.
So some issues surrounding, that involve the disabled community in this topic is like accessibility. I think a lot of like what other people had already said is like lack of education or kind of just understanding. And yeah, like they said, there is a lack of education surrounding it, whether that be like in schools or in like medical areas with help with in general. So yeah.
And then for the disabled community, there aren't enough adjustments to fit. So educating, maybe there aren't enough accessible pamphlets when maybe a pregnant woman goes to get a checkup. Maybe there aren't exactly the terms put. I don't know.
Yeah, I mean, I guess like kind of combining it with like the discrimination part, there is also a lack of like materials and resources that are accessible for disabled people. And then going into the discrimination part, there are a lot of doctors or medical people who do refuse treatment, which is illegal, but they do it anyways. And there's even like laws and policies that they want to seem like they're neutral to every person, but in reality, they have a negative impact on the disabled community. So yeah.
And this testing provides information, well, whether that the fetus can continue to be viable to full-term pregnancy. And so that brings up the topic of abortion. And so if these results come back and the fetus is not feasible, there is an option for an abortion. And so depending on the state one lives in, we now have had Roe v. Wade overturned. So isn't that awful? There's lack of access to abortion, and that is for all communities. And again, with the lack of education on abortion with sex education, that brings.
Yeah. Well, also, I think that with the disabled community, I think it is extremely difficult to get an abortion just because, like I said before, the lack of like resources or the materials that we use to have abortions. There's like, it's difficult, like it's invasive, it's different, it's, you know.
Okay.
Oh, so this is what prenatal, so they just take a blood sample, thank you, of in the arm, so that's why it's thingy in the arm. But yeah, it just tests like maybe the number of chromosomes, or if there is anything that needs to be looked at, that draws any concern that like the doctors may see. So that's just what this picture represents.
And why? So we've explained that it helps find chromosomal differences in the fetus, and it should be available to all women. But as we referenced earlier, there is a lack of equality there. So this testing can prevent the mother from undergoing harm. So if there's such as ectopic pregnancies, and these are the kind of tests that would prevent the mother from being harmed from that. And so this can also help a family prepare for their lifestyle if their child is set to have a disability. So we have some visuals of chromosomal disorders. So we have the normal male chromosome, and then we have this. Edwards syndrome, which is an extra, also called trisomy 18. It's an extra copy of the 18th chromosome. And then we have Patau's syndrome, which is more likely that the fetus will not go to full term. That is an extra copy of the 13th chromosome, also called trisomy 13. And then Klinefelter syndrome is an extra copy of the sex chromosome, the X chromosome. So the fetus is assigned male at birth, but has an extra X chromosome, which could have the child be intersex. And that's just another example of genetic differences.
Yeah, so there is a process that women go through to kind of have this test looked at. Obviously, you get blood drawn, through any treatment or just to check things are okay. But then there's something called the
chorionic villus sampling, or CVS.
Yes. And so basically it's like cells are taken from the placenta, like when you're pregnant, and it's usually performed within the 10th to 13th-ish week of pregnancy. And then there's also amniocentesis, which is basically the procedure where a small amount of fluid is taken from the uterus. So it's a little bit more invasive. And is performed after like 16 weeks. And then depending on your result, you have the choice to continue with your pregnancy if you want, but you also have the choice to like look at other options. And so this is an example of the CVS and the amniocentesis. So the placenta is the red thing.
Yeah.
And then the other thing is the fluid from the uterus that they will get. Yeah.
And in this process, there's usually, it's, as we said, invasive. There's a large needle that goes into the abdomen. So this is an uncomfortable process for most
Yeah.
So the risks of such testing, genetic testing, could be fetus alteration, which could result in fetal limb damage if the CVS is performed before the 10th week. And you could also have inaccurate results. So sometimes the NIPT test gives a false positive or a false negative, which is unfortunate. And there is just a large amount of pain that it goes into this process. Both are just, as I said, a large needle into the uterus, which is uncomfortable for the mother. And sometimes this needle, it's with no fault to the doctor performing this, could puncture the uterus or the placenta, and this could result in a miscarriage. And the mother could also undercome an infection, and because of the foreign object being inserted to be testing. Okay, here we are. So prenatal testing and screening for aneuploidy can be a very hard process to go through physically and mentally. Disabled expecting mothers have an even harder time and difficult experience than abled women, and some get dismissed, mistreated, or even denied access. But screening includes screening is an important process to make sure you have a healthy fetus and everything. So should I give you? Yeah. Okay, and then the differences are sending in a biological sample, the blood and such, and it can just really help with family planning, this process. So here are our resources, and we would like to thank you and ask if you have any questions.
Okay, well, thank you both for this informative talk. Another reminder for our audience to please submit some Q&A into our discussion. I think I'll go ahead and start things off for you two. What were some of the barriers that you found in your research for individuals with disabilities into accessing prenatal screening and testing?
Well, I think like kind of how we mentioned earlier about the it was in the earlier slides about like accessibility. There is a lot of like lack of physical accommodations available to them in the health facility, and this could include like lack of accessible exam and like diagnostic equipment, or the lack of adequate like assistance in getting into or off like an exam. Yeah.
And like with physical being uncomfortable with the physical process, there probably would be maybe that the doctor would perform with a abled person wouldn't be as comfortable for this disabled person, and maybe like there's disparities in that.
Yeah, and there's also a lack of communication. Like I think one of the previous speakers said, like talking about plain language, a lot of the times like medical people like to use these big fancy words that we don't always understand. And like even like I don't understand. And so it's a problem, like communication and like finding the right words to say it and how to say it, and also like finding the right questions to ask in a way that like makes it presentable and understandable. So yeah.
Okay, well, I'm noticing time, so let's go ahead and move on to our next speakers. Thank you both for this presentation, and we'll move on to our last presentation of the day. Thank you.
Thank you.
Hello, today we're going to talk about parent within the disability community. My name is Eleni Mazria, and this is my partner.
And I'm Alexis Herrera.
We're going to talk about parental rights, and we just want to make it known that it's not uncommon for people with disabilities to want children and raise children of their own. Taking care of a child is a big responsibility, but disabled parents have always been capable of being good parents. So why are parents with disabilities set up to fail? So in the US, 4.1 million parents have a disability. But what's concerning is that according to the National Council on Disability, the child removal rate is 80% for parents with disabilities, which is significantly high compared to able-bodied parents. For parents with disabilities, having their newborn baby permanently taken away is not uncommon. So if you're a recently mother with a disability, if a nurse is noticing that you can't properly breastfeed a child, or you just can't really show, like, you can't really detect signs of when the baby like needs to be fed, or how to, according to them, you can't really properly take care of your child. Those are motives to strip your rights as a parent permanently. And so they just take your baby away, which is not right. And at least 13% of physically disabled parents have reported that they have been treated poorly by Child Protective Services. So this slide is showing how like parents with disabilities have rights. And so what is the ADA? The Americans with Disability Act is a law that does not allow people with disabilities to be treated poorly simply because of their impairment. So how does the ADA protect disabled parents? So they guarantee protection for parents with disabilities from the bad practices of child welfare programs, which is that they make sure that Child Protective Services judge disabled parents fairly with individual assessments and not have any like implicit biases towards them. And so they make sure that CPS parental programs are also inclusive and accessible for all parents with impairments. And what's really concerning is that although the ADA does provide these protections, it's not really put into practice, and it doesn't really protect parents with disabilities from unfair child removal. So despite having parental rights, parents with disabilities are reported to CPS much more often compared to able-bodied parents. But like, why is this such a big problem? Well, it's a really big problem because disabled parents are permanently separated from their children without any proof of harm towards the child needed. And currently, at least 35 states, parents with disabilities get their parental rights completely taken away because of their impairment. So they're using someone's disability as a way to saying you're unfit to be a parent, which is wrong because it separates children from loving parents. We shouldn't let others label disabled parents as unable to provide for their child's needs.
So for our presentation, we centered it around a case study. And this involved a court case with the state of Tennessee and a person named LaShonda Whaley, who is a disabled single Black mother. And her son, JW, was taken after someone reported her to Child Protective Services. And Miss Whaley has an intellectual disability as a result of being in a car accident when she was about 9 years old. And JW, her son, suffers from asthma and several skin conditions. And the reason why LaShonda was reported was because she had not taken her son to a doctor's appointment. She had missed the appointment, and CPS saw this as child neglect and therefore took her son away and placed him in foster care. And the state also said that she could not take care of him properly without any evidence. So the court decision, the state of Tennessee said that Miss Whaley needed to be mentally evaluated and go through routine tests with doctors in order to receive a new diagnosis about her disability. And she also had to partake in parenting classes in order for her to get her son back. Eventually, Miss Whaley won her case because there was a lack of evidence against her and from the state. However, in order for her to get her son back, the court said that she had to move in with a friend from church, or else her son would be placed in foster care again, showing the disparities between disabled people and able-bodied people. So the case study shines light on inequality and that the disabled community faces. However, we wanted to focus on equitable solutions so that way this never happens again. And by doing so, we looked at government assistance and having the government create federally funded programs in order to provide childcare assistance to parents with disabilities to make parenting a little bit easier. And also having a strong support system we found is very important because this gives access to new parents the ability to talk amongst each other and give each other parenting tips and how to take care of their child.
And we also thought that it was really important that these assistance programs are accessible to all people within the disability community, regardless of race, socioeconomic status, gender, or ability. I think we think it's really important that, you know, parents with disabilities aren't just like shunned or labeled as incapable, but instead helped and provided this assistance to become even better parents and, just improve like their abilities to take care of their child. I don't think it's fair that we just say, oh, you're unable to be a parent because of your impairment, but instead say, we're gonna help you if you need some type of assistance. And I think we think it's really important that that's accessible to all. And thank you. These are references that we use to prepare the presentation. And we would like to say thank you, and if you guys have any questions.
All right, wonderful. Thank you so much, Alexis and Delaney, for this presentation. To start us off, from the two of you in preparing for this talk, before, if you had any initial thoughts about right to parent, or if that was even a term that you had heard about before selecting this topic, kind of what drew you into selecting this topic for the presentation?
I think for me, it was definitely, I'm very interested in law and I aspire to be a lawyer. So I wanted to see, in terms of the disabled community, how laws impact certain people. And as we've seen in the case study, most of these laws are discriminatory and kind of ostracize people with disabilities outside of being a parent. And we believe that being a parent is a right to anybody, regardless of having a disability or not.
Yes, and to add on to that, I was kind of really like surprised that there are these disparities to begin with. I think that any first-time parent should also be provided for like this with this assistance. But when it comes to the disability community, it's just a lot of people just think that they aren't capable enough to be parents, to be fit parents, which I think it's wrong and kind of ostracize them in a way, or just say, oh yeah, if like any slight mistake that they make, which is obviously normal if you're a first-time parent, they use that against them to say you're just not going to be a good parent at all. So guess what? I'm gonna just take your rights completely. You can't even see your child. And it's kind of hard to fight these cases because again, there's barriers with communication, understanding the terminology, and there's not assistance or enough representation for these people who do fight these cases. And I also find it like very like not interesting, but very shocking how we try to like look for cases where it did involve how kind of cases that were successfully like fought back and gave parents with disabilities their rights back. And it was really like hard to find some because half of the time they just weren't given their rights back or allowed to see their children ever again. And they're put in these foster care systems that I feel like deprive the parent and the child from having a bond that could have, been created, and just providing that nurture for that child. It's just like completely stripped away and just not giving back, which is really wrong.
Very sad reality to come to terms with. And I think that oftentimes, especially in the field of disabilities, what we come across is that just because something is legal doesn't necessarily mean that it is ethical or right. So in doing talks like this and presenting on topics and discussing these kinds of conversations, it's important to highlight these discrepancies so that we can better advocate for this community. Okay, I'm seeing a question here. In your research, did either of you find any way that Child Protective Services did provide accommodations specifically for disabled parents?
I personally, when I did my research too, like as we were working together, I didn't really see like enough accommodations. Like sometimes, like when I mention individual assessments, I'm saying like, for example, like they're putting their biases aside, what they would usually like kind of how they would evaluate other parents, but instead like be more understanding that parents with disabilities, like they have certain necessities as well, and not just use like what you would not typically, but like would you like not really discriminate them with these evaluations, but actually as a person and what like their situation is, like evaluate them based on that instead of just saying, oh yeah, you're just not fit to be a parent because you can't like change a diaper properly or something like that for your child.
And in your research, did you find any states, if any, that had either initial steps in working towards these more equitable solutions?
I didn't really look into like specific states, but I did find there are like some programs, but they're not really affiliated or as accredited like on a legal basis. So they don't really like it's more just like community service in a way, and actually like organizations that help people with disabilities have access to parenting classes and stuff like that. But yeah, there's not really in terms of the legal context, there's not really a lot of laws that protect people with disabilities, the right to parent.
Well, I'm going to take this question from a previous question from an attendee, because I thought it was a fantastic one. But for the two of you, Delaney and Alexis, in researching this topic, has it changed your perspective or motivated you to go down a certain path in the future?
I think for me, like I mentioned before, I really want to get into law, and I feel like taking this class and coming up with this presentation has really taught me a lot about injustice that all communities face, and especially the disabled community, because there's just a lot of unfair treatment that they shouldn't face, that they continue to face on a daily basis, and I think that that is wrong at all levels of humanity.
I personally feel like moving forward, I do want to do more research on how like the differences of how parents with disabilities are treated compared to like able-bodied parents, because I think it's really important to spread awareness like among our communities about these issues and how they are treated unfairly. And yeah, so I think it's really important to really educate others about kind of these disparities and how unfairly like parents with disabilities are treated compared to others.
As we often say, disability intersects all genders, all races, all economic statuses. And so it is critical to address these kinds of disparities and to make sure that we're working towards a more inclusive and equitable future. All right, well, thank you both for this wonderful presentation. It's been a pleasure. In our last couple of minutes, I am wondering, Dr. Clark, any final words? I will hand things over to you before I wrap things up from this wonderful webinar from today. I'm so impressed by all of our students and their presentations.
Thank you so much. Jasper, I have to say what a great job you did as the webinar facilitator. You handled all those questions and you came up with really excellent facilitation for all of our student presenters. I want to just say, as I reflect on the students who presented today, it's hard for me to imagine any other young college students beginning their college career who have taken a deep dive into these topics of intersectionality and justice. And I'm really very pleased that they did so. And I want to thank our audience for being here today and asking really pointed questions and giving our students a real challenge. I think that was very appropriate. So thanks to everyone for being here. Are there any questions before we go? We have another moment or two. Anybody have any questions about the class overall or any lingering questions they'd like to ask?
Give our audience another moment. Any questions for Dr. Clark in terms of the structure or the content of this class, which I think is so important, and how lucky are our students to be able to take this in their first year of undergraduate. I think that it's so important. So maybe Dr. Clark, any last words that you'd like to share with our community or with our presenters today?
No, that's it. Thank you everyone for attending. I really appreciate it.
Of course. All right. I echo Dr. Clark. Thank you everyone for attending today's webinar, Short Takes on Disability and Sexual and Reproductive Health, presented by our phenomenal UCLA students. Thank you to our presenters for their important and informative talks. For any questions, please feel free to contact the Tarjan Center and we'll direct questions to our speakers. In terms of next steps, we look forward to seeing you at an upcoming Tarjan Center Distinguished Lecture, as well as our upcoming annual forum in neurodevelopmental disabilities this fall. Otherwise, please feel free to check out our website at the UCLA Tarjan Center website and our social media for all of our upcoming webinars and talks just like this. All right, thank you everyone. Have a good afternoon.